Thanks for joining us again. As per our usual, I wanted to start off by sharing our current statistics before I hand it over to our two physician guests. So what you see, again, this data is also on our website, just as a reminder, and is publicly available. But what you'll see is our current trend chart. This is COVID positive inpatients. And as you can see, and what I've had shared in prior news conferences, is that we look to be plateauing around this 270 or so number, and that is 270 inpatients that are positive for COVID. Siobhan, go ahead and go to the next one. This is the chart that shows the difference from April 1st through our current date. The red line, remember, is 2021. So it is a substantial change compared to last summer, which I think you all know. This is new, and as a result of some of your questions last week, this shows the number of admissions for COVID to our hospital, our children's hospital. These are for individuals under the age of 18. And so what you'll see is the month of August, we were back up to about the same level of admissions that we had in January of 2021. So we'll talk a bit more about that later, but go to the next data point. This is ventilator use. It is one of the things we've commented on before, is that we're seeing in August, through the month of August, we saw more patients requiring mechanical ventilation than we did in the prior surge back in January of 2021. That trend continues. Part of that, we believe, is due to the fact that the average age of the patient is less, and so they're tending to be on the ventilator for longer periods of time than what we think we experienced back in January. This is the dashboard that is also there, so it shows you what our numbers are as of today. And again, I won't read all this to you, but just so you can just point out, we're hovering at that 260, 270 range, and that's been fairly consistent now for the last couple of weeks. I think that's the last slide. So with that, I'm going to turn it over. I think first I'll go to Dr. Campbell and ask Dr. Campbell to make his comments, and then we'll go to Dr. Hardy as well, and then take whatever questions you have.
Thank you, Dr. Robertson. I appreciate that. What we're seeing on the pediatric side of things is more admissions. And if you look nationally at the numbers, particularly between age 5 to 15, those age range patients used to be in the bottom two lines of growth of hospitalizations per 100,000 cases, but now it's consistently in the top number of hospitalizations per 100,000. Kids are more and more vulnerable to the Delta variant due to a number of different things, but our most susceptible age range are 0 to 4 years, and we're seeing those kids admitted to the hospital 10 times higher with this Delta variant compared to the previous COVID infection and winter wave of last year. At our facility, you know, that graph that Dr. Robertson showed, if you want to break down numbers, if you look from June through August, and that's our assumption of Delta variant related admissions to COVID, you're going to see about a 6.5 time increase in hospitalizations. Now, just early on here in September, I don't have the numbers, but I would say those numbers are exponentially increasing in the same consistency that they have from early June to now. And a lot of that has to do with kids getting into school, and then the spread of the Delta variant is escalating. The Delta variant is much more transmissible. Of course, in pediatrics, we're taking care of kids for the large majority are not eligible to get the COVID vaccine. And so those who are 12 and older and are getting the vaccine, they're hospitalized at a rate 10 times less than those who are unvaccinated. And so we do see that the vaccine is aiding in those 12 to 17 eligible vaccination population to to be effective and beneficial. And so it's just once again hearkening to the numbers that vaccination does decrease our risk of hospitalization as well as severe illness. What's sort of interesting is, if we look at some UK models and some other European country models of the Delta variant that hit sooner, they seem to peak about that 60-day range. Perhaps we're right there at that 60-day range of Delta variant here in Oklahoma. I'm not sure. I think the next week of numbers will kind of prove that right or wrong. But it is interesting to kind of be right there at that plateau and see how that affects the pediatric population and admissions, because what we know is that the vaccine can keep people out of the hospital. And what we know is that most of our population and pediatric populations cannot be vaccinated. So we'll see moving forward into September with more and more school days behind us if our numbers continue to escalate. And I really feel like they will. And so what I would like to harken on is vaccination is important, and masking is a mitigation role that we can play for our children if we want to lower the risk of contracting the virus, because not every school has a mandate. Most schools don't have a mandate. Some private schools do, and some charter schools do, but most have no mandate to mask. But what that means is parents can still make an informed decision, look at the data themselves, ask their pediatricians or the physicians that they trust their kids to see, ask their opinion on the masking for their children. And I think what they'll find is all pediatricians in the Tulsa area and most family medicine physicians say, please mask your children going into the school year, because it is one thing that we can do for those unvaccinated kids. And please do 12 and older, please vaccinate to protect the kids that cannot vaccinate yet. And so we'll see what happens in the next couple of weeks as school becomes more and more in swing. And I'll be open to ask or answer any questions that might be asked later on.
Thanks, Dr. Campbell. Now I think we've got Dr. Hardy. If you're available, you can make a couple of comments. Your focus has more been on caring for the patients after they've been infected with COVID. And so we thought it'd be important for you to be able to share partly what you're seeing and what you're learning from the experience of caring for patients that have had COVID.
Thank you very much, Dr. Robertson, and thank you for this opportunity to speak to the people of Tulsa at large. As with introductions, Brad Hardy, outpatient family physician with Warren Clinic since 2016. With the uptick in cases that we're seeing here within the Tulsa Metro and northeastern Oklahoma at large, I've been asked to kind of give an update as far as post-COVID syndrome specifically, and then I can answer questions kind of at large as far as what we're seeing as far as outside of the hospital. This topic is challenging given its scope, and it's incredibly broad with our understanding of the illness being still pretty limited. Something that myself and I would argue most primary care physicians have encountered at this point in the pandemic. Even myself, having suffered from COVID in October of last year, I had residual symptoms which lasted approximately 2 to 3 months, and by diagnostic criteria would be considered post-COVID syndrome. While there's no widely accepted definitions as to the stages of COVID-19 infection or recovery, the CDC proposes that we break patients into 2 broad categories, those who have acute COVID-19 and those who suffer from post-COVID conditions. So the first group is, by definition, those patients who have had symptoms for less than 4 weeks following onset of illness or positive PCR or rapid testing. Post-COVID conditions, this is a broad range of symptoms, including both physical and mental conditions that develop during or after COVID-19. And by definition, they have to be residually occurring 4 weeks after onset of symptoms and cannot be explained by an alternative diagnosis. Other terms that have been thrown around in regards to post-COVID syndrome include long COVID, acute or post-acute SARS-CoV-2 infection, post-acute COVID-19, or chronic COVID-19. Looking at these 2 groups, acute and chronic, from a public perspective, acute COVID-19 individuals are going to be seen by the public as the patients who get sick, have to get hospitalized, become ventilated, or even die. they are perceived as the ones who are affected and or seriously harmed by this illness, while the latter group kind of gets forgotten. Fortunately, most people who catch COVID-19 won't become severely ill and get better relatively quickly. However, significant numbers of patients do suffer long-term health problems after recovering from the original infection. Unfortunately, explaining the pathophysiology of post-COVID syndrome or long COVID is incredibly difficult and not really understood at this point in time. One possibility that's been hypothesized is that the infection makes some patients' immune systems go into overdrive, attacking not just their own, or not just the virus, but their own tissues. And this would then allow the virus entry into those cells, prolonging symptoms. Similarly, due to lack of understanding, it's almost impossible to identify who will suffer the effects of long COVID. What we do know with certainty is that we see increasing prevalence with age, and that younger patients with less comorbidities are less likely to have residual symptoms, which is good, as Dr. Campbell pointed out, with the spiking that we're seeing in that pediatric population in regards to the Delta variant. One of my good friends, his kids actually tested positive over the weekend, and they just didn't know what to do. So I got a call Sunday morning about that. Additionally, higher incidence of post-COVID syndrome is seen in females for whatever reason, with likelihood of developing this illness approximately twofold. That being said, about greater than 50% of those who are hospitalized for COVID report symptoms lasting longer than 2 months, in between that 2 to 12 months range, making them by definition post-COVID syndrome patients. And a study out of Wuhan earlier this year showed that 12 months post-discharge on a cohort patient population of 1,700, of those 1,700 patients who were discharged, 49% of them have residual symptoms 1 year later from COVID-19. The most common symptom in that study was fatigue and muscle weakness, followed by shortness of breath and anxiety. Circling back, persistent physical and mental symptoms lasting longer than 4 weeks is the diagnostic criteria for post-COVID syndrome once you rule everything else out. So you need to make sure these patients don't have an underlying pneumonia or have some other medical problem that's been undiagnosed or missed that could explain their symptoms, such as new onset COPD or something of that nature. These symptoms can range from mild to severe and can affect up to a third of post-COVID positive individuals. The most common physical complaints with post-COVID syndrome are fatigue, followed by dyspnea, chest pain, loss of taste and smell, and cough. Again, my own personal experience from October of last year was that of chest pain, and it lasted for approximately 2 to 3 months. We live on a rather large hill, and taking our trash in and out for a good 3 months after testing positive, I would experience not crushing, but substernal chest pain, where if I wasn't 36 years of age, I would have questioned if I was actively having a heart attack. It was very unsettling, and when I brought this to the attention of my wife, she became very concerned. And I'm a physician who's well versed in medical literature and what's going on in the community, or not going on in the community, but going on in the scientific community. And just for that patient who is uneducated or hasn't spoken with their physician, this could be incredibly unsettling. So I kind of touched on this earlier, but patients experiencing post-COVID syndrome may also have psychological presentations. Anxiety is reported in approximately 23% of individuals, and 18% of individuals suffer from depression. There's neurocognitive complaints such as poor memory and concentration. These psychosocial, or not psychosocial, but these physiological manifestations are very similar to those experienced by patients who've been in the ICU for weeks on end. For other medical problems, we see this. It's not just limited to COVID, but the prevalence is much higher in COVID. I've had approximately 5 or 6 patients in my practice who've had to resign from their jobs or move forward with long-term disability related to the neurocognitive component of post-COVID syndrome. And these were highly functioning individuals. One gentleman that I'm thinking of was in his mid-40s and was a small business owner of approximately 50 person business. And he had to essentially take a step back and tap his VP to step into his shoes because he was unable to perform his duties. With that, you see incredibly high instances of depression and anxiety. All
Dr.
patients who suffer.
Yeah, Dr. Hardy, let me just ask you a quick question because
Yeah.
that provokes a thought. So do you, when you see these folks that maybe 2-3 months post-infection that are still symptomatic, as a primary care doc, how do you how do you follow them? I mean, I know at this point, there's probably not much you can offer them from a treatment perspective, but what might a patient expect if they've been diagnosed with COVID and then 2 months later, they're still feeling,
I mean, if I haven't
well.
seen them in office, I'm going to want to see them in office, especially, I mean, anybody who's symptomatic with COVID-19, if they have a severe course of illness or sequelae associated with their illness, I'm going to want to see them in office as soon as they're no longer contagious, to lay eyes and ears on them, get a chest x-ray, rule out these other things that could be contributing to their symptoms, do pulmonary function testing, we see a high incidence of pulmonary embolism in these individuals who are hypercoagulable and sedentary, secondary to the severe fatigue. So, I mean, you're going to want to make sure that they don't have a pulmonary embolism or a blood clot in their lungs. Once you've essentially ruled out the other things that could be on the table, I mean, there's only so much we can offer. As far as the Tulsa community, I'm seeing some infectious disease doctors write for IV infusions of high doses of vitamins. You know, I'm not really seeing medical literature to support that, but I mean, people are kind of grasping at straws, wanting to get their quality of life back and return to their activities of daily living. And like I said earlier, the depression that goes along with this, that's definitely something that we can help. And I'd ask patients to reach out sooner than later if they start to fall into a depression, especially going into the winter months when there's decreased daylight, there's limited ability to be outside. And then kind of like Dr. Campbell said, I fear this winter is going to be very scary when it comes to COVID. We all hope that 2021 was going to be the year, or, the light at the end of the tunnel. But unfortunately, that doesn't seem to be the case so far.
Yeah, thank you. Hey, Dr. Campbell, same question for you. Are you seeing kids post-COVID? And if so, what's been your experience in your clinic so far?
Yeah, thanks for the question, Dr. Robertson. I'm only inpatient, and so I don't have a clinic that I follow patients in, so I haven't seen any post-COVID clinical situations.
What, from your colleagues that are obviously in the outpatient practice world, what have you heard or seen from them? Are we having the same concerns about this post-COVID syndrome in children? I guess that's the short question.
Sure. Yeah, it's a good question. And I don't think there's as much data driving that, or clinical visits driving post-COVID situation for the pediatric population at large. Now, I have heard that, the older adolescents that very much body habitus mimic an adult with maybe a larger BMI and maybe already some comorbidities with diabetes, those seem to have an increased risk of sort of the post-COVID syndrome. But I have not heard any particular murmurings about, in general, pediatric populations having the post-COVID syndrome.
Okay.
What I've read is I haven't seen it seen it documented nearly as much in the pediatric population, but we are seeing higher incidents in comparison to 6 months ago or 12 months ago in regards to that younger demographic of adults, those 20, 30, 40-year-olds, just because they're the ones who are kind of unvaccinated. At this point in time within the Tulsa community, 65 and over, the vaccination rate is greater than 90%. So, I mean, they're more likely to be protected from developing this in the first place.
Yeah, good point. Hey, let's open it up to the media for any questions that they might have for any of the three of us.
Hi, this is Bert Momolo from Channel 8. Would you guys like to see more action from either state or local leaders when it comes to mask mandates? The school TPS, they're not using the word mandate, it's an expectation. The city last week, said, it's a resolution basically. What are your thoughts on that? And, you know, the headache of getting into the politics of it while you're trying to save lives?
Well, I'll answer first, and then I'll let my clinician colleagues answer secondarily. But you know, we are obviously, as a health system, our role is not to be in the middle of the politics. We're not a political organization. What is important to us is that we do everything we can possibly do to educate our community. And in the instance of whether kids should wear masks or not, you know, we really believe that parents need information, and with that information, they can make the right decision for them and their kids. We've said publicly, and I'll say again today, that if there was a mask mandate, either locally or more broadly, we would not be opposed. We would support a mask mandate, because masking is a tool that we all have to protect ourselves and our loved ones. But it's one of many tools. The vaccine is another tool. Just good old-fashioned hand washing and social distancing are other tools we all have to protect ourselves and our families. And so we're trying to reiterate that point over and over again, and provide information to those that come to St. Francis for care. So that's from the St. Francis perspective. My clinical colleagues will have their own perspective, and I'll let them answer.
I'll answer as well. Bert, thanks for the question. You know, if you're looking at roles of trying to decrease the spread of the virus, the modalities that we have are filtration, distancing, immunization, and masking. And so masking is controversial, and I wouldn't want to step on anybody's individual liberties. However, as a physician, I will say masking does mitigate the spread of illness. That's true for COVID, as well as respiratory syncytial virus and influenza and rhinovirus and adenovirus and all the other viruses that are spreading this time of year. And so masking does decrease the risk of exposure. And so personally, my kids are masking at school. I know they're just one of the few, but I am having my own kids mask, and I do support it.
I would echo, or thank you, Bert, for the question. And I agree with both Dr. Robertson as well as Dr. Campbell in that you know, it is a personal decision, but at the same time, studies have shown that masking decreases the spread of this virus in conjunction with influenza, RSV, all the things that Dr. Campbell mentioned. This past year, we virtually had no influenza within Tulsa, just because of masking and social distancing, and not having a mask mandate within Tulsa at that point in time. I think of the people who are vulnerable, whose vaccine didn't have an immune response. My best man at my wedding, his wife, suffers from multiple sclerosis. She unfortunately is unprotected at this point in time. And when she's, you know, she socially distances, she doesn't go into crowded places, doesn't eat in restaurants, but still, you know, going in to pay for her gas, she could potentially be exposed. And I think about those individuals or the pediatric population who aren't a candidate for vaccine at this point in time. You know, politicians will say that there's inconclusive evidence in regards to masking, in regards to how well it works. But if you ask any clinician, physician, anybody who actually studies science, I mean, there's universal acceptance.
Thank you.
All right, I'll jump in if I can. It's Russell Mills at KRMG Radio. And Dr. Robertson, early on, you mentioned something, and I wanted to make sure I was clear on exactly what you were saying. You said that younger patients are staying on ventilators longer. Do you mean that's because they survive longer? I mean, I hate to put it in those brutal terms, but I think that's what you were saying.
So for any of us, the better shape we are in, the better health that we're in when we contract COVID, the higher the likelihood that we'll survive. What we know, and this is something that's seen around the country, is that once patients get to the point of requiring assisted ventilation, mechanical ventilation, the likelihood that they will not survive the infection increases dramatically. And so what we are seeing is, because we have now a little bit younger group of people that are at that stage of the disease that they are requiring, ventilation via a machine, they tolerate it better. So what we might have seen in January, where folks were either quickly turned around and got well and got extubated and were able to, go home to be, discharged. What we're seeing now is, those folks that are younger and in better health tend to, if they don't get better, they also don't die as quickly either. So I guess it is very sensitive, but it is true that we are seeing folks that are requiring mechanical ventilation, and that it is lasting, that they're not improving quickly so that we can extubate them, but they're also not continuing to deteriorate to where they no longer survive.
Okay, fair enough. I hate to ask you guys to speculate. Well, let me ask you this first, real quick. We know that the virus is spread in a respiratory manner, but once it enters the body, is it developing into more of a vascular disease? And would that help explain some of the long haul stuff and some of the complications that we're seeing, like the brain fog and, clotting and that kind of thing? Or is the science still sort of working on that answer?
We know that it affects those pathways. The question is how. I don't think that from a pathophysiology standpoint, that's completely understood. Initially, they were thinking about talking about microembolisms and stuff of that nature, just because we were seeing, essentially heart attacks in these individuals who would go in and get cathed in the cath lab by a cardiologist, and their vasculature would be clean. So, I mean, it's still something that we're learning about from what I've read. I don't think that there's a clear-cut etiology. Dr. Campbell may have further insight, or Dr. Robertson, but from my perspective, that's what I've read or identified.
So it's essentially still kind of an open question, because we just haven't had enough experience and gathered enough data to be able to figure it out. Is that fair?
I think that's fair.
All right. And finally, I'll ask this question. It's kind of open-ended, and you may not want to even take a swing at it, but I mean, we're looking at a fall that's way worse than last fall. Are you guys anticipating a winter that's way worse than last winter? Because, I would presume, Dr. Robertson, that you're making contingency plans for that to happen, but gazing into the next couple of months, what do you guys expect to see?
Well, I'll start. Dr. Campbell mentioned we're about 6-8 weeks into this, at least in Tulsa and sort of northeastern Oklahoma. We're about 2 months into this most recent wave. And what we've seen historically around the country, and I think actually around the world, is the way this virus behaves. We get these little waves, but they, for the most part, at least in a local geography, tend to create their maximum impact somewhere between 6 and 8 weeks, and then they subside. The test positivity rate starts to decline, and then the number of admissions start to decline, and the numbers of hospital inpatients declines. So I can't say. All I can say is that if this virus behaves, if this variant behaves as previous variants, we may be plateauing out now and start to see a downward trend in the number of sick patients. But we don't know, given Labor Day, given schools coming back to in-person learning, we don't know the ultimate impact that that's going to have. And so I'm not sure that I would make a bet at this point that we're done, quote unquote, with this wave. I don't think we can predict that yet. From the wintertime perspective, we as an organization believe that we just have accepted the fact that COVID is going to be with us, and it may be endemic. It may just be at a low level, and we periodically get, little upticks in terms of numbers of infections. And so we're just preparing to continue to provide care, to take care of people that don't have COVID, in spite of what's going on with COVID, because there's still, unfortunately, tons of illness that needs to be cared for, regardless of what's going on today with COVID. And I'll let Dr. Campbell speak to it from a pediatric perspective.
Yeah, Russell, on the pediatric side of things, we've kind of coined this term swinter, kind of a summer winter that we've been having with increased numbers of admissions of COVID as well as other viruses. Dr. Hardy had mentioned flu and RSV and other things had diminished greatly, and that's absolutely true, but then they started upticking in May and they continue to go on the rise. And so the numbers projected moving forward is not specific, but I would say that if we continue at this rate, we're going to see a very severe winter. Also, something to keep in mind on the pediatric side of things is with the Delta variant, with us being pretty young on the Delta variant and its effects on the pediatric population, we haven't seen an MISC related to the Delta variant. So that's that multi-system inflammatory syndrome that we saw with the pediatric population with the regular circulating COVID. We haven't got far enough out from the Delta variant to appreciate those type of cases yet and what those will look like. And so that'll be something to watch in the upcoming months and see how that's been affected by the variant. And so, yeah, I think, you know, like Dr. Robertson said, as inpatient provider myself, I've been here quite some time and I've seen a large load of patients over that time for different reasons. And I expect this winter to be one of the worst that I've seen. I hope I'm wrong. I really do. I hope I'm wrong. But I think we're in for a large number of admissions and patient care.
Well, thank you very much, everybody at St. Francis, for doing this. Very much appreciated.
Thank you.
It looks like Daniela with Channel 8 had her hand up.
Yeah, so we talked to another hospital system today who had to expand their mobile morgues because of, you know, the number of deaths. Is that something that St. Francis is looking at doing or at that point yet? Or if not, when would you guys get at that point where you need to expand?
You know, it's not something that that I'm aware of that we're planning to do as of now. I mean, obviously, the number of mortalities is always concerning, but at this point, no, we're not planning on expanding our morgue, at least not in the short term.
Thank you.
Well, if
like
no other
Mason.
questions.
Oh, Mason Morrow.
Yeah, sorry, Dr. Robertson. I'm going to jump in. I'm Mason from Channel 2. Thanks again for joining us this week. This one's probably directed for Dr. Campbell here. We got an email earlier today kind of highlighting some concerns for special needs kids in fighting off the virus, asking the community to get vaccinated for them. Is this of high concern to pediatrics, and are you seeing a lot of them admitted in that population?
Is the question, do I see higher special needs cases related to COVID? Is that the question?
Yes. If you have that data.
Sure, I don't have that data. But, you know, as far as getting vaccinated for special needs, I say get vaccinated for all the children because they're at a vulnerable state because they don't have any mitigation avenues except for masking and social distancing. So not just special needs kids, but all children, please vaccinate for them.
Hey, this is Chris Polanski with Public Radio Tulsa. We've been seeing hospital systems across the state. Comanche County just put overflow tents up right before we started here. Is that something St. Francis is thinking might be in the future?
Well, what I would tell you is that, you know, we feel like we're at a plateau now in this portion of Oklahoma. And so no, we're not thinking that we will need to, nor are we planning for any, you know, capacity creation through the use of tents. Now, again, you know, a week from now, I may be delivering a different message, but if you just look at the number of inpatients we've had now for the last couple of weeks, we've been relatively stable. So we're not seeing the increases that we were 3 and 4 weeks ago. I also look daily at the number of patients we admit with COVID as a diagnosis, as well as the number of patients we discharge. And we've been discharging more people than admitting pretty consistently now. Most days are pretty close. We may admit 19 and discharge 20, but the trend has been we're not admitting more than we're discharging. So that explains why our census has stayed flat.
Thank you. And just in terms of resources, I've heard other hospitals in Oklahoma talk about it being low on certain supplies like oxygen for patient care, body bags, I heard recently. Are there any things that you need or that you've run low on or run out of late?
No, we keep a close eye on all of those critical supplies. I would tell you that given the fact that we've got more COVID positive patients requiring ventilator support than we did back in our January peak, we are using more medications that are the type of medicine that make it more comfortable for the patient who's on a ventilator. So there are certain things like some of the pharmaceuticals that we're using just because there's more demand for them, and we're keeping obviously close eyes on that. But at this point, and I would be aware if we were facing any significant supply shortages, we're not. Again, we're also maybe in a different place than hospitals in central and western Oklahoma because we've already begun to plateau in terms of the number of inpatients.
Thank you.
Amanda Gilbert here with Fox 23. Based off of something we saw nationally, do you have any doctors refusing to treat unvaccinated adults?
Great question. I've not heard that is the case. And what I would say to my physician colleagues that would consider that as an appropriate approach, our job is to provide care, is to do no harm. And we frequently take care of patients that may have made choices that were different than choices we would make personally. But as clinicians, as physicians, and quite frankly, all of our staff as caregivers, our first obligation is to provide care to patients in need. And so I wouldn't encourage that approach from if there were clinicians inside our organization that were advocating for that, I would have a much different opinion.
Thank you. And one more question for a reporter working on a different story. Do you guys have any comment on Governor Stitt's removing 2 board members from the Oklahoma Healthcare Authority? I think they are the only 2 medical doctors on the board.
I don't have any comment. I'm not familiar with the situation, nor do I know the individuals, so I wouldn't hazard a comment.
No problem.
We have time for one more question. Anyone?
I'll ask if no one else wants to jump in. Dr. Campbell, your grim outlook that you've kind of, I guess, given on this upcoming winter, is that solely because of the spread in schools that you fear? And obviously there were a lot of schools in distance learning last year. Would that be a good way of mitigating? And do you think that some schools should consider that this semester?
Well, I hate the word grim. I don't have a grim outlook. Hopefully, I just want everybody to be aware of the rise of the Delta variant and what its impact on the pediatric population is, because it is impacting the pediatric population differently than the previous year COVID strain. I think we just have a good opportunity right here as pediatric providers and healthcare providers just to provide education to the population and to just talk to families and say, hey, have a discussion about how we're going to handle risk exposure for COVID. How is it important to our family? What steps can we do to perhaps decrease our risk of exposure? And what do we do when we're sick? And as long as families are talking about it and coming up with a plan that's healthy and diligent for themselves, then I think we'll be in better shape than if we just sort of ignore what the data has been showing us. So I don't want to have a grim outlook. I just want to be fully informed.
Okay, thank you.
You bet.
Well,
That was a good segue to my announcement for this week. St. Francis is partnering with Tulsa Public Schools for a vaccination clinic this Saturday at their Education Service Center from 10 a.m. to 2 p.m. TPS students can register online through their website. Other children or adolescents that would like to attend can walk in, and we'll be happy to serve them as well. And as always, anyone can schedule a vaccination on our website at stfrancis.com/get-vaccinated.
Hey, Lauren, I presume that they need a parent or somebody with them. They can't just walk up, a 13-year-old and say, hey, give me a shot.
Correct.
Thank you.
Good question.
It's at the Education Service Center, you said, right?
Correct. 3027 South New Haven Avenue.
And I want to just close by, first of all, thanking Drs. Campbell and Hardy, not only for their time today, but their service to the community. And I also want to thank all of you in the media, because we do very much appreciate the fact that you're willing to spend some time with us every Monday. As I started off, our goal is to just provide information. And I think Dr. Campbell said it very eloquently, which is ultimately we want people to make good decisions, and you can do that when you've got when you have the information and you have multiple perspectives. And so we hope that through you we're able to provide another perspective in regards to this disease, this virus, and its impact, particularly its impact on those of us that are on the side of delivering care, and because we see something that maybe is a bit different than what folks just out in the general public would see. So thank you very much for your assistance, and we'll see you next week.